good afternoon, and welcome everyone to this month's Fireside Chat in recognition of Kidney Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. Our dedicated team is committed to reducing the burden by engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. I am Amna Hussein, the Community Outreach and Engagement Manager on our team, and on behalf of our entire team, I extend a warm thank you to everyone who's here today. In alignment with Kidney Cancer Awareness Month, our discussion today highlights kidney cancer, also known as renal cell cancer. According to the American Cancer Society, kidney cancer ranks among one of the top most common cancers for both men and women. The stealthy nature of its symptoms often means the disease remains undiagnosed until it has significantly progressed. In today's Fireside Chat, we'll explore the complexities surrounding kidney cancer, its risk factors, symptoms, prevention strategies, and the latest advancements in detection and treatment. It is with great honor that I welcome today's speaker, Dr. Subodh Regmi. Dr. Regmi completed his training in general surgery and urology from the All Indian Institute, of Medical Sciences in New Delhi, India, before arriving in Minneapolis, Minnesota for a urologic oncology fellowship at the University of Minnesota. He has been in practice for several years before finding his calling in oncology. He strives for patient-driven cancer care by empowering patients to collaborate and be actively involved in decision-making and informed decision-making. Dr. Regmi's clinical and surgical interests are in bladder, prostate, kidney, and testicular cancers, and has expertise in robotic surgery. As a distinguished urologic oncologist at the University of Minnesota, Dr. Regmi brings a wealth of knowledge and expertise to today's topic. We will be recording today's Fireside Chat, so you can refer back to the recording on the Masonic Cancer Center's YouTube page. For University of Minnesota employees and spouses participating in the University of Minnesota Employee Wellbeing Program, you can earn your wellbeing points for attending today's Fireside Chat by completing the form that will be in the chat shortly. Before we begin, I would like our audience to get familiar with using the Q&A feature located on the bottom center of your Zoom screen. During today's session, please use the Q&A feature to submit your comments, questions, and reactions. We have time carved out at the end for some Q&A. All right, without further ado, I will now pass things over to Dr. Regmi. The floor is all yours.
Thank you, Amna, for this wonderful introduction, and I'm happy to be a part of this Fireside Chat, which I understand has been going on for the last couple of years at least. And I find this as a really good opportunity to engage myself with the community and be part of the Masonic Cancer Center's community engagement project. So thank you so much for this opportunity. And without further ado, I will share my screen here and go right into the talk of understanding kidney cancer basics. I've tried to keep it as simple as possible for our general audience to understand. And if they have any questions, they can certainly feel free to answer, have them put up with the chat, on the chat, and then I'll be happy to answer them for them. All right, thank you so much. And I'm going to start now. So this is the Kidney Cancer Month, March, and we're going to talk about the basics of kidney cancer, starting right off with what are the kidneys, where are they located? Most of us would be familiar with that, but just to refresh our memories, these are paired organs located in the upper abdomen, close to the back and hidden very nicely with the rib cage. It does come in close proximity to other organs like the liver and the spleen on the right and the left side, respectively. And if you look at the right-sided image here, it is divided into, regions which forms the meaty part of the kidney. That's what I like to call it, which is called the cortex. And the collecting system, which collects actually the urine from filtered from this meaty part of the kidney and then drives it down the ureters into the bladder. So two distinct zones, lots of blood supply. It is one of the most vascular organs in the body, just because it works as a very highly efficient filtration mechanism, and it works to clean and filter our blood so that all the impurities and waste products are removed in the urine. It maintains a balance of fluids so that we're not overloaded with fluids. It also maintains electrolytes and acid-base status. And there are several hormones which are produced from the kidney, which play a significant role in the daily maintenance of our bodily functions. Most important of which is maintenance of our blood cells, as well as maintenance of blood pressure. So all of these factors are also highlighted when kidney function is deranged, or even in rare situations where there are kidney tumors. So what's a kidney mass or a kidney tumor? That's the other question that comes into mind when you start talking about kidney cancer. Any abnormal growth is a tumor or a mass by its strict definition. And therefore, any kidney tumor or mass can either be benign, which is non-cancerous, or malignant, which is cancerous. And kidney cancer can either be an indolent or a quiet kind of a cancer, or it can also enlarge and spread out of the kidney to other organs. Interestingly, with the advent of newer diagnostic technologies, meaning CTs and MRIs, and the frequency with which we are using them for other situations, the number of smaller indolent kidney cancers are being diagnosed at a higher frequency than they were maybe 40 years ago. So certainly the number of kidney cancers that are diagnosed now, as well as the number of benign tumors in the kidney being identified, is certainly higher than what it used to be in the past. And if you just look at all of kidney tumors in general, 1 in 4 could be benign and non-cancerous. So it's important to kind of distinguish and not be alarmed by the fact that, hey, they saw a mass in the kidney and be worried about it being cancer right away. You need to seek proper advice and be sure that, hey, is this a cancerous lesion, or are we just dealing with some benign tumors? So the first question, I've tried to put some questions in this talk as if I was someone listening onto the talk and had to put some questions to the speaker. So I've tried to put my presentation in such a format that it's a question and an answer kind of a format, so that it's easy for us to go through the talk. So the first question I have is kidney cancer that big of a problem? We always talk about prostate cancer, which is probably the commonest cancer in men, and the second most largest killer of men in terms of cancer after lung cancer. But nobody really talks about kidney cancer that loud. But is that a big problem at all? So let's look at the statistics here. In 2023 in the United States, it was estimated that almost 82,000 people would be diagnosed with new kidney cancer. That's a significant number. So yes, it is a significant problem. It affects men more than women. If you look at the statistics that was estimated for the last year, almost 53,000 men and about 30,000 women. And then death-wise, almost one sixth of all the patients who would be diagnosed may die of kidney cancers. So almost 15,000 there. Worldwide, similar statistics. It's less common in different parts of the world. There are some racial distinctions that we can see, and we'll talk about that. And much more common in the Western world, and specifically in the United States, the incidence is higher than as compared to, say, in the Asia Pacific region or in other parts of the world. The incidence rates are rising 1% per year, and as I said earlier, it is because we are doing more imaging tests for other unrelated conditions that we end up diagnosing these kidney cancers, which is a good thing, because as you remember, I'm saying that most of these kidney cancers operate in a stealth mode. and sometimes are not clearly evident when they present early. However, with the advanced treatment modalities that we have currently, the death rates are going down, and based on the statistics of the past decade, reducing by about 2% compared to the last decade. Survival-wise, if you compare the overall survival, and when we say survival, it is the relative chance of being alive at 5 years with the cancer diagnosis is about 77% for overall kidney cancers. But when you divide that into early stage, when the kidney cancer is still confined to the kidney, not outside the kidney, and compare it to metastatic kidney cancer, you see that there's a stark difference. So that is why it's important to understand that early diagnosis and treatment is of paramount importance in kidney cancers, where you can drastically reduce or improve the survival of the patients who get diagnosed each year. So this is something that I want to highlight as an important thing for us to understand, that early diagnosis does work wonders in terms of curing or surviving the cancer with good outcomes. The other question, and there were some questions which were provided to me earlier, and I think this will answer some of the concerns there, is that are there any disparities seen with kidney cancer in terms of difference between the different genders, racial differences, and disparities based on socioeconomic or insurance status, for that matter. So yes, there are. Like any other disease in our country, there are several disparities that exist in kidney cancer. Gender-wise, females are less likely to get affected with kidney cancer than men. And in terms of racial predisposition, it's much more common in African Americans than Caucasian Americans. The statistics for native population in mainland US as well as Alaska is not robust, but whatever statistics we have, if we look at that, it kind of paints a very stark picture of a highest incidence in Native Americans as well as Alaska Natives as compared to rest of our racial group. So it is pretty, considerably interesting to see that there is a stark difference in different races. Even if you look at the different types of kidney cancer that can occur, a particular type, which is the papillary cell renal cell cancer, it's much more common in African Americans, whereas the more garden variety clear cell cancer is the commoner cancer in Caucasian Americans. This is a nice cartoon that I borrowed from the American Association of Cancer Research, which kind of looks at the disparities across different spectrums and tries to identify those in specific cancer groups. So in kidney cancer particularly, if you look at dividing these disparities, we find that there are several disparities that exist, and I've kind of outlined that here in this cartoon. We talked about the racial differences as well as the differences in socioeconomic status. So they have a significant impact in survival from kidney cancer. People who have no insurance or are on Medicaid as compared to private paid insurance have much less chances of surviving kidney cancer as compared to people who are of a good socioeconomic status or, as I said, have a private paid insurance. There may be some differences in terms of locations due to the lack of accessibility to the standard of care at times, and the delays that one may experience in terms of diagnosis. And kidney cancer commonly is more prominently seen in older adults. So commonly seen between the ages of 64 and 75. That's the most common group of our population that gets the disease. But more common in terms of genetic predisposition, younger patients may also get this cancer if they have a strong genetic history of kidney cancers. And we'll talk about that in a few slides. The other question is, are all kidney cancers the same? the kidney is made of two distinct regions and two distinct parts. So can all kidney cancers be the same type? No. The renal cell cancer is the most common type, and there are several pathological varieties of a renal cell cancer. We don't need to go into the details of that, but I will briefly touch that in the next slide. The other type that I talked about was the part arising from the collecting system of the kidney, which forms about 10 to 15%. And we're not discussing that because usually the treatment and management of urothelial cancers in the kidney are similar to bladder cancers because they behave like bladder cancers. Sarcomas are rarer tumors, more aggressive tumors, where treatment protocols are not very well defined, but pretty well known in terms of what works best for these sarcomas. Wilms tumor is a common children's kidney tumor where treatments have evolved over the past many years, and there have been remarkable changes in protocols where we have been able to preserve much of kidney function in most of the children who are diagnosed with Wilms tumor. And that's not the focus of my talk today. Lymphomas are atypical tumors. We all know they're from the cells that populate the lymph glands, but sometimes, rarely, they can be isolated into the kidney's lymphatic tissue. Very rare, and it's one of those situations where it's a diagnostic dilemma for the treating physician. But once identified, the treatment is fairly streamlined and straightforward. So these are the common types. We don't need to dwell more on these, but the most common type is the clear cell. And that's where most of the treatment protocols, guidelines have been established. For other cancers like papillary cancer and chromophobe cancers, there is a very clear defined role of surgery. The role of additional immunotherapy, chemotherapy is being investigated and highlighted in these other cancers. The last three varieties are not very common. And there isn't a whole lot of guideline about medullary or cortical or collecting duct cancers. So important here is to understand there are so many types of kidney cancers that can occur, but when you look at them in general, what are the risk factors? If you look at yourself and say, hey, am I at risk? So you may want to look at this chart here, which is another cartoon I took from one of the papers recently published in JAMA that looked at the risk factors associated with renal cell cancer, and it very rightly categorized them into modifiable and non-modifiable risk factors, and risk factors that are environmental and possibly related to occupational exposure. Non-modifiable risk factors may be age, family history, genetic syndromes like VHL syndrome, and the sexual predisposition for men to be more likely affected with kidney cancer than women. There have been reports and associations with different chemicals, specifically trichloroethylene, which is like an industrial solvent, which have been used as a degreasing agent in industries, as a paint solvent. So exposure to these are significantly associated, along with other chemicals like asbestos, benzene. There used to be a drug which has been off the market called phenacetine, which is associated with a particular type of kidney cancer. The modifiable factors are the ones that are most important for us to understand. These are the factors that we can change ourselves so that we can prevent or at least decrease the risk of kidney cancer for us. Obesity, cigarette smoking, alcohol, a lack of exercise, and high blood pressure. So these are all associated very significantly with kidney cancers, have been proven in different studies in the past. A brief note about hereditary cancers. Most important of these is the VHL syndrome. About 60% of patients who have VHL may develop kidney cancer. And there has been a significant advance in this treatment of this particular kind of cancers. The reason for this is because most patients will have multiple episodes of recurrent cancers in both kidneys, which is devastating. And recently, there has been a drug that has been approved, and I will talk about that briefly at the end. But other hereditary cancers like hereditary papillary renal cell cancer, Britt-Hogg-Tooth syndrome, hereditary leiomyomatosis, tuberous sclerosis, which mainly causes non-cancerous tumors, but about 2% people may have kidney cancers as well, and other rare varieties are highlighted there. The important syndrome here is the VHL syndrome, which is pretty remarkable in terms of how frequently people with VHL have kidney cancers. So after briefly overviewing these risk factors, we look at the risk reduction or prevention strategies here, and we have to look at the modifiable risk factors, as I said earlier. So let's go back to that cartoon here and just focus on these modifiable risk factors. So how can we prevent? We can prevent or reduce the risk by working on these factors: obesity, checking on your weight, making sure you're fit, active, working out. Cigarette smoking, if you're a smoker, stop it right away, because that has been seen to be associated with the reduction in cancer risk for many, many cancers. Similarly, alcohol use, heavy drinking has been associated with RCC. Lack of exercise, all of this is also associated with that. And interestingly, high blood pressure, if it's uncontrolled, has a significant association with kidney cancer. In general, preventing kidney cancer also involves leading a healthy lifestyle. So if you are considering lifestyle alteration measures, that's a right move in the right direction, because it significantly helps you out in reducing your overall cancer risk, not just kidney cancer. How do the kidney cancers present? As Amna said, they're stealthy. So in most situations now in my clinic, they are incidental. We just find them in a CT or an ultrasound that someone has done. But at the same time, there are patients who present with symptoms and signs which are very typical of kidney cancer. So just this cartoon that shows that more often it's a lump that they feel, or they feel this discomfort in the abdomen or the lower abdomen or the backside. Advanced cancers present with the other symptoms of fatigue, unexplained weight loss, appetite loss, blood in the urine, because it can significantly involve the collecting system of the kidney, as well as other features like fever. Interestingly, there is a group of syndromes which I have not shown here, but that can be associated with the kidney cancers. It used to be called the internist tumor in the past. The reason being, people had advanced disease, 70, 80 years ago when they presented with kidney cancer, and they, just didn't know where that symptom was coming from. And this was because of the various chemicals and proteins that the tumor would produce that would be baffling to the internist who was evaluating this patient. So these are called paraneoplastic syndromes. People may have high hemoglobin, have high blood pressure, have some, other unusual symptoms of high calcium levels, and we're just wondering where is the cause. So much less commonly seen nowadays, but sometimes we do see them, especially in large renal tumors, but that's an unusual way of presenting. And as I said, most commonly it's either ultrasound or CT detected, or maybe someone presenting with a vague pain in the abdomen or a lump that they can feel. They come to the clinic to have that looked at. So this is a scenario that I wanted to talk about, two drastically different scenarios that I see my patients here in the clinic with kidney cancer. One is a hypothetical patient here, 65-year-old, was seen by the primary care doctor for some vague abdominal pain, and CT done by the primary care with concerns of maybe stones in the kidney, and the CT showed a mass, and then he or she gets referred to my clinic to have a discussion about management options. The other side of the spectrum here is say this is a hypothetical 70-year-old person presenting to the ER who's bleeding and he's passing clots in his urine and has a severe new onset pain in his flank, and the ER physician gets a CT done, and then also feels a palpable lump in the abdomen, and has a large kidney mass, and now it's involving one of the major veins of the abdomen, the inferior vena cava. So these are the two different spectrums, widely contrasting to each other, but we still see them. So anything in between it can present with, but as I said, most commonly it's incidentally found nowadays. So how do we say that it is a kidney cancer? So there are several ways or tests we rely on. These are what we call diagnostic tools: clinical examination, feeling your belly, finding the mass, localizing it to the kidney, urine tests to check for blood in the urine, blood tests to see kidney function, or as I said, the other abnormalities that kidney tumors can sometimes produce. These are also used to, see your fitness for surgery, the fitness of the surgery of the patients, as well as their general overall condition. But most importantly, it's the imaging test that we employ to diagnose kidney cancers or kidney masses. Ultrasound, CT, and MRI. Ultrasound as a preliminary measure, more specifically CT of the abdomen with contrast, and MRI are very helpful. In about 90% of the cases, we don't go beyond this if we are thinking of, say, a surgical resection, because this is good enough for diagnosis. But in situations where the diagnosis is in doubt, as I said, lymphoma, we're not sure if this is actually a true tumor, or we think this looks like a benign tumor and a radical treatment would sometimes be an overtreatment, then we go ahead and do a biopsy, which essentially means taking a tissue sample out of that kidney mass, usually through a percutaneous approach, which means a needle pass through the skin under ultrasound or CT guidance by the intervention radiologist, and the pathologist looks at these tissue samples under the microscope and gives us a diagnosis of whether, hey, this is your kidney cancer. Oh, no, this is a benign mass. Or, hey, this is a lymphoma. Maybe you should send it to the medical oncologist for chemotherapy. So in those situations, we would employ a biopsy, not on a regular basis. So someone's been diagnosed with kidney cancer. How do you know what state is it at? It depends on the size of the kidney mass primarily. If it's, say, less than a baseball size, it's usually deemed as stage 1, that's 7 centimeters or less. And there are two sizes to that, stage 1A and stage 1B, where it's roughly the size of a golf ball, which is about 4 centimeters or less. Then it's stage 1A. That's the earliest stage you can have, and stage 1B is between the golf ball and the baseball size. When it's larger than 7 centimeters, but it's still confined to the kidney, it's stage 2. Stage 3 is when it's coming out of the kidney. As you can look in this cartoon here, it's coming out of the kidney into the fat around the kidney. Then it's stage 3. Stage 4 is when, and also, sorry, I forgot to mention this, if there are lymph nodes which seem to be involved by the cancer around the kidney, that's stage 3. Stage 4 is if the cancer progresses and involves the adrenal glands. These are the surrounding organs of the kidney that's next to it, or goes to a distant site from the kidney, so the lungs, liver, brain, bones. Then we consider this to be a stage 4 or metastatic disease. And you can see certainly the difference in the disease extent between an early stage and a late stage disease. And that kind of is self-explanatory at times about the significance of survival outcomes even with treatment. So how will we treat these cancers? There are several modalities as well as specialists involved in treatment of kidney cancers. Urologists or urologic oncologists would be the primary drivers of these care in most of the situations, as well as the medical oncologist would be actively involved in treating these patients. The role of the radiation oncologist is somewhat limited, the reason being in the past that this was thought to be a radio-resistant cancer. That concept is changing now to a certain extent, and we probably will see more involvement of the radiation oncologist down the line. So it's kind of a team effort here. On top of that, you'll also have your navigators, your coordinators working with each of these specialists and specialties, trying to drive the care of the patients who are diagnosed with kidney cancer. So the options of treatment are several. For the indolent cancers, meaning the cancer that are small in size, are slowly growing in size, we do have a surveillance. There's also an option of ablation for smaller tumors where an actual invasive procedure is like surgery is not done, and we are able to ablate by either heat or cold the tumors to a really good extent. Surgical resection has been the mainstay of the treatment for kidney cancer for many, many years, and will continue to be so for many more to come. A new therapeutic modality called targeted therapy and immunotherapy has been rising, and especially for advanced kidney cancers and metastatic kidney cancers, it's kind of changed the whole paradigm of kidney cancer care. And I'll briefly deal with that in the next few slides. And radiation therapy has a very defined role in special situations, and there are newer facets to the radiation therapy in the years to come. So surveillance is basically with imaging, with CT, MRI, or even ultrasound in especially smaller kidneys, usually less than 2 centimeters in size, where we monitor them every 6 months to a year using these different modalities, ensuring that these are slowly growing indolent tumors and perhaps do not need any treatment down the line. So say, someone got a CT for a back pain, found that there was a 1 centimeter solid tumor in the kidney. Now we are faced with the situation of what to do next. The best option here, say they are, 78 years old and have, 15 different other medical issues, is perhaps to do surveillance and not rush them to potentially a complicated surgery. And just, sometimes they may not need any treatment at all, and surveillance might be enough. So surveillance is a good modality for smaller tumors or indolent tumors, because often it is noticed that these tumors grow at a very, very slow rate and do not perhaps need any treatment for someone's lifespan. The other option is a minimally invasive option called ablation. This is done mostly through the skin or percutaneous, where you put in these probes from the skin into the kidney mass here. The cartoon on the left shows cryotherapy. The white dense stuff is the ice ball that forms around the tumor because of the freezing that is brought in by these probes that are implanted into the tumor for the duration of the treatment. And the freezing and thawing of the kidney tumor over a couple of cycles kills these cancer cells. And it's a fairly effective way of treating these smaller cancers. So as I said, for the stage 1A tumors, this is a good modality. For larger tumors, there may be sometimes, extension of their indications, but generally reserved for these smaller tumors where a bigger surgery may be avoided. There's a slightly higher recurrence rate, but then again, second ablations are possible, can be done. And this is something we commonly employ as a part of our treatment armamentarium for patients with kidney cancer. Surgical resection, as I said, has been the mainstay of treatment for many, many years. It either involves surgery for the cancers that are localized to the kidney, and even for, cancers that are outside the kidney in situations where, say, there's only one site of metastasis, say, to a part of the lung. So the thoracic surgeon may be involved in removing that metastasis when the urologist, has removed the tumor from the kidney. So partial means only part of the kidney is removed. Radicals means the entire kidney is removed. And these surgical approaches can be done via the traditional, open incision, where you make a big cut in the abdomen, which may be necessary for bigger tumors. But in smaller, even reasonably sized tumors, we now do employ on a routine basis laparoscopic keyhole surgery, where you make smaller incision with the help of these instruments and mobilize the kidney, and then make a slightly bigger incision to remove the kidney, or even use robotic surgery, which has kind of changed the whole scenario of surgical management for kidney cancer patients for the urologist, just making surgery so much more easier in terms of the wide range of motion that it provides, as well as making complicated resections possible, because it provides such a fine way of doing things. So as I said, partial is when you just remove part of the kidney in smaller tumors, and radical is when you remove the entire kidney. As you can see here, the difference between the left and the right side of this picture here. If you go back to the last slide, in the partial, you have just removed the part of the kidney that was having the tumor. A brief discussion about other therapies like targeted therapy, immunotherapy, and chemotherapy. Chemotherapy is not so much popular unless it's, I said, urothelial cancers, because traditionally kidney cancer has been resistant to chemotherapy. With the resurgence of various targeted therapies and immunotherapeutic drugs, there has been now a whole paradigm shift in how we manage metastatic disease, as well as in situations where, say, the disease is locally advanced, which means if it's a big tumor going out of the kidney, but still, localized within the abdomen, there may be some role of these immunotherapeutic drugs. And then there are several combinations and permutations that the medical oncologists have worked on through years and years of research, which is now bearing fruit in terms of cancer outcomes. So definitely this will have an impact on survival of patients who have metastatic disease. So how does targeted therapy work? It works on, these, if you look at this cartoon here, there are these blue horseshoe-shaped structures, which are these receptors present on different cells, more commonly expressed in cancer cells and less commonly in normal cells. So that this targeted therapy is tailored to target these receptors, which are more common in the cancer cells, and kills them off in a very efficient and effective way. There are several targeted therapies available. I will not go into the details of these and how they work and what their side effects are. But basically, this has been the main basis of treatment for many years in the early 2000s, which has now evolved into immunotherapy, which has been somewhat much more beneficial than even targeted therapy. And now people are moving on to permutations and combinations of using immunotherapy as well as targeted therapy for better outcome on patients. And if you look at immunotherapy in general, this cartoon on the left, encompasses whatever is kind of whatever is encompassed by the term immunotherapy. In kidney cancer, most commonly it has been the immune checkpoint inhibitors and cytokine therapies that have dominated. And there has been an emerging role for vaccines in several different cancers, and I'll talk briefly about this in the next couple of slides. But these are the different drugs that have been used, and several combinations are available, treating different situations in metastatic and advanced kidney cancers. Radiation therapy is not in the front line of treatment, but it's for palliation. Say someone has a bone metastasis, which is painful and very bothersome. Radiation comes into play. Lung metastasis may need, SBRT, which is called a higher dose of radiation, which is focused and precise, and can be used in those situations too. And the newer role I will talk in the next couple of slides here. After initial treatment, there is, as with any other cancer, a profound follow-up period that is needed to detect any recurrence of the cancer. And we use tests like blood work, imaging like CT or MRI, and then these schedules for this follow-up based on what the initial stage was at diagnosis. So say stage 1A may not need such a very stringent follow-up, whereas stage 3 needs a more strict follow-up. And then the follow-up also involves treatment of and managing cancer-related side effects, say from the treatment itself, and complications that may arise. And this involves a complex work between the oncologist, the urologist, as well as the primary care providers, who are a very important part of this care for follow-up. A brief mention about survivorship. Most cancer centers like ours, the Masonic Cancer Center, does have resources for cancer survivors who have beaten cancer or are living with cancer. And you should work with your primary care, your cancer coordinator, to work on a care plan, which involves a lot of things, follow-ups, managing your overall health, your other medications, for that matter, your expenses, your finances, and this all comes as a part of the survivorship plan. You can look into resources at our website here with the the University of Minnesota, the survivorship.unn.edu. There is even a Kidney Cancer Association patient navigator program. It's actually based off Texas, but it's available for anyone within the country. And then they have really good resources to help patients with kidney cancer with. As our own effort, the Department of Urology does organize the Climb for Kidney Cancer event each fall at the Huntington Stadium. That's what it's called now. And we organize this for all our cancer survivors, patients, families of cancer patients. And we climb the stairs of the Huntington Stadium in fall. The last one was in September last year. So hopefully we'll have an event this year as well. But yeah, this is what we have been doing. And just as a matter of note, there is a survivorship conference next month. And I hear that there are still openings there to join this and understand how this works for all patients. So what are the recent advances? Finally, I will talk briefly about that. You must have heard about this. It's called liquid biopsy, where we do blood tests, which looks at various different aspects of cancer, which are called circulating DNA, circulating cancer cells. Even there are some products of cancer that can be traced. And this is still investigational, but it's coming up in a big way in different varieties of cancer. We can use both blood samples and urine samples for kidney and urothelial cancers, and they may have a really profound effect on early diagnosis, in predicting the prognosis of cancers, as well as devising treatment strategies. When you look at different genomics, that's the genetics of cancers, we could prioritize or personalize treatment for individual patients, for that matter. So this is something that we have to keep a lookout for. This will will be very interesting to follow in the years to come. As I said about the radiation therapy, there have been a couple of trials that have shown really good promise in treatment of primary kidney cancers with this high intensity focused radiation treatment called SBRT. So in patients who may not be good candidates for surgery, this is something which may be a part of the treatment armamentarium in the future. Robotic surgery has been there for nearly 20 years now, but with the experience that we've been gaining with robotic surgery, we've been able to do more complex procedures on the kidney, even do situations where the kidney cancer is advanced and going into the IBC thrombosis. So that's been part of the advancement that robotic surgery has given, that major procedures can be done in a minimally invasive way with greater recovery and earlier recovery. Other emerging trends, like for inherited disorders, there is a new targeted therapy called belzutifan available. It has been approved by the FDA. And for that matter, as I said earlier, targeted and immunotherapy combinations have become effective and have been part of the standard protocol for advanced kidney cancer. Future prospects, vaccines, very interesting. These are personalized vaccines. There's been a trial which has completed recruitment, and we'll be expecting results maybe in a couple of years. It's called NeoVax, which looks at harvesting your cancer cells and developing vaccines from them and injecting them, and it's been used to see if that can prevent, along with immunotherapy, further cancer recurrences. There have been several other efforts at vaccines in the past, but none of them have been as promising as this one. They've just completed, I think, a stage 1 trial, clinical trial, and we'll have to wait for more results to come out in the future. So thank you for your patient listening. I know this probably was an exhaustive talk. I tried to cover most things that I think would be questions from a lot of us, but my take-home message are, yes, kidney cancers are common. They're not the uncommon cancers. It's the top 10 cancers in the country, so they are common. Interestingly, screening tests are not available. It's very difficult to diagnose, and most people get diagnosed incidentally nowadays, or still they may have some advanced features when they present. We should focus on preventing strategies, especially smoking reduction and weight loss and healthy lifestyle measures. All of this go a long way, even maintaining your blood pressure, controlling your blood pressure. All of that goes in a long way in preventing kidney cancers. Newer research is focusing on earlier precise diagnosis, things like liquid biopsy. and combination treatment strategies with immunotherapy, targeted therapy, and neuromodalities like vaccines may have greater prospect for us in the future. So thank you so much for your patient listening. I hope I didn't take too much time there, and I want to be available for questions and answers if you have any.
Dr. Regmi, thank you so much for that enlightening presentation. I mean, the depth of the information that you shared about kidney cancer today not only enhances our understanding of this disease, but also empowers us to take action towards prevention, detection, treatment, and just what's available, the resources for patients and their families. So thank you so much. So as we move into the next phase of our session today, we invite you, our audience, to join the conversation. So this is your opportunity to engage directly with Dr. Regmi. We invite you to submit the questions that you've been hanging on to using the Q&A feature, and then we'll try our very best to address as many questions as time permits based on the time that we have left. And it is not a fireside chat for those of you who have been tuning into our fireside chat. It's not a fireside chat discussion without getting our fire started. So just going to get that started real quick. And I think we'll go ahead and dive right in. So I see there's a question that was just submitted. Do patients with a history of kidney stone have a higher incidence of developing kidney cancer?
So Mary, thank you so much for this question. No, typically not. Most patients who have kidney stones do not have a higher risk of kidney cancers, but very, very, very rarely in situations where there have been, large obstructing kidney stones which have been neglected and forgotten, sometimes have associated kidney cancers, which are not the usual kind of kidney cancers that we see. But the short answer to your question is no, but yes, rarely there may be some associations, but not significant enough to be concerned of.
Perfect. So there was another question. Does acute kidney failure lead to kidney cancer?
Not so much as acute. So patients who have chronic kidney failure or end-stage renal disease and are dialysis dependent, there is a condition in the kidneys called the acquired cystic disease of the kidney that happens with long-term dialysis that is associated with a particular type of kidney cancer. It's called the papillary kidney cancer. Thankfully, it is not as aggressive as, say, the clear cell kidney cancer, but nevertheless, it needs treatment with surgery. So yes, chronic kidney failure with history of dialysis is associated with kidney cancer, but not acute kidney failure.
As a follow-up to that, there actually was a question that was submitted just to touch more on dialysis treatment and it being a risk factor for kidney cancer. Why is that? Can you speak a little bit to why that might be the case?
Sorry, what was the question again? I didn't get that.
So in relation to dialysis treatment, is it a risk factor? You mentioned that it might be. Why is that?
Yeah, so as I said earlier, there are changes in the native kidneys. That's the kidneys we are born with. That happens because of dialysis. It's because of the fact that the dialysers that we use have certain changes that occur within the blood, as well as the the large amount of potential toxic waste that we have to be exposed to, causes these changes in the kidneys called acquired cystic disease of the kidney. And this disease can be associated with kidney cancer.
Thank you. So what is the importance of comprehensive tumor profiling in kidney cancer? How important and useful can lipid biopsy be?
So it's still being investigated, liquid biopsy. There have been potential roles of it in terms of, say, early diagnosis. So if you look at circulating tumor cell DNAs or circulating tumor cells, even methylation products that come from as a part of the cancer tissue's metabolism, it can lead to early detection. Comprehensive tumor profiling down the line may be very beneficial in terms of managing the patients for personalized care. Say if someone has a particular genetic mutation that was detected and there is a target therapy available for that, and certainly this profiling would be very beneficial. Say for, if you're profiling for VHL mutations, you may be able to use belzutifan for those patients. So that's what we have currently, but over the next many years, we would be able to, identify or personalize care for patients with comprehensive tumor profiling.
Thank you. We're gonna try to go through these. There's been quite a few questions that have been submitted. I love the engagement. So do people with family members who have had a kidney removed due to a tumor have a greater likelihood of developing cancer?
Possibly, yes. A family history of cancer is significant for kidney cancers too. Depends on what age that the kidney cancer was diagnosed. I would say if someone was diagnosed with kidney cancer at an earlier age, one. If someone has a family tree, you can trace that, hey, my aunt had kidney cancer and her mom had kidney cancer. And now am I at risk? Certainly, possibly, yes. You may be at risk. In those situations, it is advisable to discuss with the genetic counselors that, hey, what is the risk of, developing a kidney cancer? Are there any tests that they could do to see their genetic susceptibility to kidney cancers? And certainly that's something that, we could do. At this point in time, genetic testing, we don't recommend right away unless you do have an identifiable genetic syndrome in the family, say like VHL syndrome. But yes, a significant family history, depending on when it was diagnosed and how many members of the family have had that cancer, there is certainly a heritable risk for you.
Thank you for that. Are kidney donors at any higher risk of developing kidney cancer? Is there anything in particular they should be aware of when it comes to kidney cancer?
Not that I know of. I don't think there is an increased risk by just donating the kidneys. Because, the concern often is that, hey, am I going into kidney? Am I at a higher risk of developing chronic kidney failure because now I just have that one kidney? But studies have shown that people, the likelihood of going into chronic kidney disease is not that high not higher compared to the normal population. So just by donating kidneys, you're not at a higher risk because you're concerned about the risk of going into chronic kidney disease. What you can still work on is things like hypertension. You just have that one kidney to work with, and hypertension is independently associated. High blood pressure is independently associated with the kidney cancer risk. So the modifiable risk factors like high blood pressure, prevention of smoking, a healthy lifestyle, maintaining your diet, trying to avoid obesity, all of that may be a little more important considering the fact that you just had one kidney to work with than a person who has two kidneys. But apart from that, there isn't an increased risk just because you gave one kidney to someone.
Good information to know. So we've had this question submitted a few times. So what information is known about renal solidary fibrous tumors? Is it hereditary? What is the recurrence and survival, and how rare is it?
Oh yeah, it's a very rare renal tumor. I shouldn't say privileged, but I've not seen that in my practice, and apparently it's maybe like 100 cases in the world where people have these tumors that have been diagnosed. It can be aggressive, locally aggressive, and it can metastasize to other parts of the body. So when we deal with these tumors, the treatment is aggressive surgical approach. There isn't a approved therapeutic measure in terms of chemo or immunotherapy because it's not so common, right? But in general, aggressive treatment, like how you would treat an aggressive kidney cancer, is how we approach these with significant follow-up in terms of imaging and managing a disease outside the organ as needed. But there isn't a guideline to say, hey, this is how you treat the solitary fibrous tumor of the kidney. So it is an aggressive cancer, but yes, it's not something that we have established protocols or guidelines on.
I mean, that's good to know that it's only 100 cases in the world. So
yeah,
it speaks to
actually, I actually went back and looked into the literature to see if there was any, a higher percentage. But similar tumors can, occur in other parts of the body, and again, they are not very common.
Okay. So we'll ask you just about 2 to 3 more questions here. Can you comment on reoccurrence rate following nephrectomy?
So it depends on the stage of the disease. So that's very important to realize what was the stage of the disease and the grade of the cancer. In situations where it's, say, a stage 1A disease, meaning it's less than 4 centimeters in size, the recurrence rates are very, very low. 5-year cancer-free probability is about 93%. So, there's a 93% chance that you won't have any recurrence, cancer-related recurrence or death in the next 5 years. So that's pretty high. But when you compare it with a high-grade, locally advanced cancer, like something that's gone into the lymph nodes, a stage 3 cancer, then the recurrence risks are much higher. The survival is, say about 35 to 40% in stage 3. So it drastically decreases from stage 1 to stage 2. And when you look at stage 4, it's 15%. So it's very highly recurrent and aggressive as the stage and the grade of the cancer increases.
Okay. So what can healthcare providers and public health professionals do to reduce some of the racial disparities that we see in kidney cancer?
Great question. Thank you for asking that. Important to realize is, we should, and here comes the work of the public health professionals too, is to ensure that, people who are at higher risk, especially, people beyond the African American population, as well as the Native American population, realize that we are at a higher risk of developing these cancers and identifying, making sure that they are aware of this, and, in situations where they have any symptoms which could relate to the kidney cancers, be aware and bring them out to the primary care providers. Interestingly, though there is a slightly higher risk of occurrence of these cancers, the most stark differences come in, treatment-related outcomes. So in most situations, in most cancer, even in prostate cancer for that matter, we have realized that poorer survival and the disparities that are highlighted by that are because of, lack of accessibility, lack of being able to access the specialized care that they need. So I think the focus should be on making access easy for all patients who are, affected with kidney cancers. And I think that's the message that we should take, as well as, try to spread it out with our public health professionals that, hey, we need to improve our access. And, I know we are as a group working on that in the Twin Cities. And I think this is something that should resonate throughout the country. Is access is important, because even though the incidence rates are higher, the more stark issues are, outcomes of treatment. And this may just be because, someone doesn't have a good enough insurance, so he can't get the advanced, therapies that have been recently approved by the FDA because the insurance doesn't pay for that. So a lot of it has to relate to the access, insurance, and, just knowing what is available. So all these resources should work to kind of try to decrease these differences in the disparities that we have in treatment outcomes, as well as incidence rates.
Great, thank you. And I think you kind of speak to that, like information and education is so crucial. So thank you for highlighting that. So we are at time, but I want you to just please take one moment to share one key takeaway that you want our audience to take from your conversation today. So in other words, what is the most important message or action item that you want to leave our audience with?
Yeah, so, I'd say 2. Can I say 2? Is that okay?
Of course, yes.
So one is, kidney cancer is not uncommon. All right, let's face it. It's one of the top 10 cancers in the country. It's not uncommon. And 2, a lot of the modifiable risk factors can significantly impact the risk we may have in developing these cancers. So stop smoking, start, on a very healthy, lifestyle regime. Try to work on getting your weight down. If you have high blood pressure, work on it, keep it under control, work with your primary care. So all of this goes a long, long way in preventing or decreasing the risk of kidney cancer.
Amazing. Thank you for leaving it at that note. So we're going to have to wrap it up here. Thank you everyone for the engagement. It was such a robust discussion and we could not get through all the questions, but I'm sure Dr. Regmi would not mind if you reach out and have any other questions for him. So
Absolutely.
a special thank you to you, Dr. Regmi, for just joining us today and for your commitment to illuminating this critical health issue. So after our session ends today, Zoom will populate a window for you to complete a brief survey for us. It would help us continuously improve our offerings. So please just spare a few moments of your time to provide us with your thoughts and feedback. And after you submit the survey, don't close the window just yet because there is a link to enter a drawing for a chance to win a prize pack filled with goodies from the Masonic Cancer Center. And join us for our next Fireside Chat on April 17th from 1 to 2 in recognition of Head and Neck Cancer Awareness Month. And lastly, be sure to follow the Masonic Cancer Center on all of our social media platforms to stay up to date on announcements and events from the Office of Community Outreach and Engagement. Thank you again, everyone, for your time today. We look forward to your continued engagement. Have a wonderful rest of your day. Dr. Regmi, thank you so much for your time today. Take care, everyone.